Yeah, like. So, good evening, everyone, and welcome to the Expert webinar. I take this opportunity to welcome you all on the behalf of Zuventus Gromax. I'm Harshadat Savan, and we have with us our uh, eminent speaker, Dr. Rahul Samanta, who will address the topic which is regarding exocrine pancreatic insufficiency and diabetes that may coexist, and despite of its high prevalence, little is known about the clinical consequences and its management. So our today's topic is challenges in the management of coexisting EPI and diabetes. Dr. Rahul Samanta is a renowned gastroenterologist from Kolkata. He pursued his MBBS from prestigious Rajendra Institute of Medical Sciences, Ranchi, and MD Medicine from the Government Medical College, Surat. He pursued his DNB gastroenterology from Apollo Gleneagles Hospitals, Kolkata. He is a prestigious member of Society of Gastrointestinal Endoscopy of India and American College of Gastroenterology. He has obtained his fellowship in advanced endoscopic ultrasound. I request all the viewers for any query kindly type the content in chat box. After the session, these queries will be addressed by Dr. Rahul Samanta. So, doctor, over to you. I'll share presentation. Yes, sir. Yes, doctor, you can start.
Thank you for the kind introduction. So today we will talk on a very common topic, that is diabetes and exocrine pancreas. And as we know that diabetes from our point of view, diabetes is important because in diabetes, as the duration of disease and the severity of disease increases, the chances of exocrine pancreatic insufficiency also increases. So it is very important for the viewers present over here to understand what are the common symptoms which we commonly see when the patient develops a exocrine pancreatic insufficiency, and how to manage these conditions. So next slide. So the agenda for today's discussion will be the epidemiology, the connection, pathophysiology, diagnosis and classification of pancreatic diabetes, management, pancreatic enzyme supplementation, and finally the conclusion. Next. Next. If you look at the prevalence of diabetes in India, around 7.3% is the prevalence of diabetes in India. And if we look at the prevalence of exocrine pancreatic insufficiency in type 1 and type 2 diabetes, we can see that type 1 diabetes has a more exocrine pancreatic insufficiency, which comprises about 74% in comparison to the type 2 diabetes, which comprises about 54%. Next. If you look at the just back if we look at the global prevalence, it is diabetes comprise about 8%, and 10% of all the new diabetes cases diagnosed could be of diabetes of exocrine pancreas, and approximately 40% of all the patients with diabetes show alteration in the exocrine pancreatic morphology. So DEP is generally underdiagnosed and usually mistaken for type 2 diabetes until it is diagnosed. Next. So if you look at the diabetes, how it affects the exocrine pancreas. So whenever the patient has a diabetes, they, there is dysregulation of the exocrine secretions due to the diabetic neuropathy. There is atrophy of the exocrine tissue due to the lack of local tropic insulin effect. Local or the general vascular damage is also there. Autoimmune mediated inflammation is there, and some genetic predisposition is there. All these things leads to exocrine pancreatic insufficiency. Next. So there is a high incidence of pancreatic disorder in the diabetes. So in case of pancreatic diabetes, around chronic pancreatitis comprises of around 76%, followed by hemochromatosis, pancreatic cancer, and the cystic fibrosis, which comprises around 8, 9, and 4%. Next. So exocrine pancreas, it generally affects the endocrine pancreas. So how it affects? Because exocrine pancreas proteases affects the function of endocrine pancreas. There is overexpression of pancreas proteases, increased number of beta cells, and there is integrated blood flow between the endocrine and the exocrine pancreas. Next. So exocrine acinar cells, they also has a crosstalk with the beta cells. So whenever there is a genetic mutation, it can lead to a pancreatic dysfunction followed by diabetes, which leads to the increased endoplasmic reticulum stress and finally leading to the beta cell dysfunction. Next. So diabetes, it results in a marked change in the pancreas. So this was a study which compared about the pancreas in the people with a type 2 diabetes and without diabetes. The key difference in the type 2 diabetes and the non-diabetes were in the patient with the type 2 diabetes, the large size of the pancreas was there, more exocrine fibrosis was there, more inter and intralobular fat was there, more acinar to ductal metaplasia was there, higher prevalence of pancreatic intraepithelial neoplasia, more small vessel angiopathy, and they have a greater T cell percentage as compared to those without diabetes. Next. So there is a structural and functional relationship also. If you look at the insulo-acinar axis, the outflow of blood from the islet, it drains into the acinar capillary network, and thus the exocrine pancreas, it receives at least a part of its blood flow coming through the nearby islets. The exocrine parenchyma and the endocrine isolate, it lie in intimate contact, and the relationship is because any capsule does not surround the pancreatic islet, so there is a close contact with the islets. So any disease which affects the exocrine pancreas, it also affects the endocrine pancreas because of these insulo-acinar axis and the blood flow. Next. So, as I have told in my previous slide, so whenever there is an exocrine pancreatic disorder, say for example in chronic pancreatitis, it leads to the increased pancreatic pressure, leads to the activation of the pancreatic stellate cells, and it leads to the increase in the type 1 collagen, leading to pancreatic fibrosis. And the endocrine disorders which affects the exocrine pancreas, like insulin, as we know, it has a tropic effect on the surrounding exocrine tissue. So there is an increase in the exocrine secretions in response to the insulin. And the exocrine pancreatic insufficiency with a body mass index and vascular disease, they suggest a pancreatic dysfunction in type 2 diabetes. And autoimmune neuropathy in the diabetes may end up with exocrine pancreatic insufficiency. Next. So coming to the pathophysiology. Next. So alcohol consumption, as we know, gallstone, metabolic risk factors, environmental risk factors, and genetic risk factors, they all can lead to acute or chronic pancreatitis. And sometimes if the patient undergoes any pancreatic surgery like a total or a partial pancreatectomy because of any malignancy or some benign conditions, pancreatic agenesis like cystic fibrosis, hemochromatosis, and cancers, all these can lead to decrease in all cell subtypes within the islets of Langerhans, and these can lead to impaired release of the incretin hormones, leading to suboptimal postprandial insulin secretions. This also leads to insulin secretory capacity, decreased insulin secretory capacity, and it finally leads to hyperglycemia. Next. So as in my previous slide, I have told in exocrine pancreatic insufficiency like chronic pancreatitis, increased pancreatic pressure uh, leads to the activation of the pancreatic stellate cells and hyperglycemia, and there is dysregulation of the known to damage the beta cells. Malabsorption of the nutrients in the EPI results in a decrease in next. So coming to diagnosis and classification. Next. So how to diagnose diabetes? So this they have classified diabetes of pancreas origin into three types. That is type 2 diabetes mellitus. Uh,
So I
more than
think, yeah, we are having a connection loss in between. Can you repeat the point, please?
okay. So for we have classified into three types. That is type 2 diabetes mellitus, post pancreatitis diabetes mellitus, new onset diabetes after pancreatitis. So as we know, type 2 diabetes mellitus, it can be diagnosed when the HbA1c level is more than 6.5. But for the post-pancreatic diabetes mellitus, generally the patient do not have diabetes manifestation before the onset of the diabetes, and they develop that features of diabetes in next 90 days. So for diagnosing post-pancreatic diabetes mellitus, again the criteria is same, that is the HbA1c level is more than 6.5 and or the fasting blood glucose is more than 126. And for the non new onset diabetes after pancreatitis also, they have the same criteria of HbA1c more than 6.5 and or fasting plasma glucose of more than 126 milligram per deciliter. Next. Next slide. So they have classified into post-pancreatitis diabetes mellitus, that is post-acute pancreatitis diabetes mellitus or post-chronic pancreatitis diabetes mellitus. The criteria is same, that is HbA1c more than 6.5 within 90 days, pancreatic cancer-related diabetes mellitus and cystic fibrosis-related diabetes mellitus. And they have also added some special entities like antecedent diabetes mellitus in the pancreatitis, new onset diabetes in the pre-symptomatic pancreatic ductal adenocarcinoma. Next. So what are the factors that suggest the EPI, the patient with a diabetes is going into exocrine pancreatic insufficiency? So if the patient has a change in the histological structures of the pancreas, if the patient has a long duration of diabetes with a poorly controlled diabetes, and more important from the gastro point of view is the symptoms, like if the patient has abdominal discomfort, pain, if the patient is losing weight, if the patient has a diarrhea, bloating and gas. So in that case, from the gastro point of view, we can suspect that the patient with a diabetes is going into a exocrine pancreatic insufficiency. Apart from that, the pancreatic atrophy or a volume change also indicates about the pancreatic exocrine insufficiency. Microvascular and macrovascular complications, if the patient is with a diabetes, with a long-standing diabetes, is developing a micro and macrovascular complications, then it is a hint that patient is going into exocrine pancreatic insufficiency. And laboratory findings suggestive of exocrine pancreatic insufficiency, which we commonly do, is the fecal elastase test. So if the fecal elastase is less than 200, so if the patient is going into a exocrine pancreatic insufficiency. Next. Like those who need, if the patient diabetic patient is requiring insulin, if the patient is uncontrolled diabetes or early onset diabetes with a history of a pancreatic disease, or a patient has a more severe diabetes, or the patient has a chronic diabetes. So all these diabetes patients, subgroup of diabetes patients, are at a very high risk of developing exocrine pancreatic insufficiency. Next. So how to manage exocrine pancreatic insufficiency? So it was a nationwide study which compared about the risk of insulin initiation, diabetic complication, and mortality between diabetic of exocrine pancreas and type 2 diabetes without prior diabetic pancreatic disease. So when they compared it to those of type 2 diabetes, they have found that diabetes of exocrine pancreas was associated with a higher risk of insulin use, hypoglycemia, diabetic neuropathy, nephropathy, retinopathy, and coronary artery disease, CVA, and peripheral arterial disease. And besides all these, all-cause mortality was also higher among the patients with diabetes of exocrine pancreas. Next. Pancreatic insufficiency in diabetes, it leads to improvement of the symptoms like steatosis, nutrition.
Hello, sir.
Next slide.
Sir, we were not able to hear you out. I think there is a network error. Can you repeat this slide, please?
Okay, so what are the benefits of management of exocrine pancreatic insufficiency in diabetes? So when we treat patient with exocrine pancreatic insufficiency in diabetes, so it leads to improvement of the clinical symptoms like steatoria. It improves in the malabsorption. It has reduced the next. So, what are the goals of management of exocrine pancreatic diabetes? So, the main goal is to control the hyperglycemia by attaining a HbA1c level of less than 7, to manage the exocrine deficiency, to manage the nutritional status, and to manage the abdominal symptoms. Next. So, coming to the management principles, so whenever the patient has an exocrine pancreatic insufficiency, it requires a multidisciplinary approach, which includes a diabetologist, specialist diabetic nurse, diabetic specialist, dietitian, a gastrointestinal and hepatologist, and some pain management. So the main principles are about the control of the diabetic therapy. Like metformin is the first line therapy for which we generally start. And if the patient is not responding to the metformin therapy, we can add on some other oral hypoglycemic agent to the such patient. So insulin is generally required in the diabetes secondary to chronic pancreatitis. And if the oral treatment fails to control hyperglycemia, in that case also we can go for a add-on therapy with insulin. Coming to the management of the exocrine insufficiency, the clinical manifestation, as we know, it manifests when more than 90% of the pancreas is affected. Thus, replacing it with a PERT therapy, that is pancreatic enzyme replacement therapy, it should be initiated in those in patients with pancreatic exocrine insufficiency. And the other point, management like nutritional management and exercise are very important. And for the nutritional, it is necessary to prevent the malnutrition and all the micro and macronutrients which are deficient in a patient with a pancreatic insufficiency. And most important is that those who has developed pancreatic exocrine insufficiency because of CP, they should stop consuming alcohol and smoking. Next. As per the American College of Gastroenterology Association, also they say about the same thing. That is, we have to counsel for to the PERT therapy. We have to do specific attention to the glycemic control, specific dietitian support, and a frequent monitoring until the condition is stable, and structured exercise plan and pancreatic enzyme replacement therapy. Next. So, coming to the early management algorithm, so if the patient with a routine diabetes, if the patient has a GI symptoms in a patient with diabetes, the GI symptoms like abdomen pain, bloating, discomfort, flatulence, diarrhea, if the patient is losing weight, if the patient is steatoria, and if the patient is altered glycemic control, and so in that case we can think of a exocrine pancreatic insufficiency, and we have to evaluate the patient for the pancreatic exocrine insufficiency. So we have to send for the fecal elastase if the fecal elastase is less than 200, and if we are suspecting that the patient is alcoholic and the patient has uh, other features of chronic pancreatitis, so in that case we have to go for imaging also. For imaging, we can go for either endosonography or a CT scan just to rule out any malignancy in a patient with a chronic pancreatitis. And after all those things, if the patient comes under a pancreatic enzyme insufficiency, so in that case we have to start with a PERT therapy. So we can start the PERT therapy with we can take either with food or after food, but as per the guidelines, they generally recommend to take the PERT therapy with food. And in my subsequent slide, I will discuss about the dose of the PERT therapy. And if the patient is not responding to the PERT therapy, we can titrate the dose upward depending on the response of the patient. Apart from this, dietary advice, general measures, and glycemic controls are also important. Next. So what if the patient is not responding to the PERT therapy? So if we have started a patient on a PERT therapy, if the symptoms are not controlled even after 4 to 6 weeks, so in that case we can consider increasing the dose of the pancreatic enzyme replacement therapy. We can also consider prescribing a PPI therapy, and sometimes if the patient is not responding, then we have to evaluate the patient to rule out other causes. Say for example, it is very common in the patient with a chronic pancreatitis, the patient to develop small intestinal bacterial overgrowth. So if the patient is not responding, just rule out SIBO and consider prescribing a PPI therapy. And if the patient is not responding, then we have to Next slide. So coming to the pancreatic enzyme supplement. So what are the benefits of pancreatic enzyme supplementation? So it has been found that it considerably improves the clinical parameters. It significantly reduces the postprandial sugar levels. It significantly reduces the glycosylated hemoglobin. It improves the sense of well-being, and it also reduces the abdominal symptoms of pain and steatorrhea. Next. So approach to treatment with pancreatic lipase, if the patient has symptoms that do not manifest, generally the symptoms of the exocrine insufficiency do not manifest till the duodenal lipase level it falls less than 5 to 10% of the normal postprandial levels. So in such cases, we should do certain tests like fecal elastase to rule out whether the patient has pancreatic enzyme insufficiency. So if the patient has pancreatic enzyme insufficiency, we can directly go for a PERT therapy. In such patient. So generally the PERT therapy is started at a lower dose, around 25 to 40,000 international unit of lipase per meals, and with minor meals we generally give 20,000. So in our practice and most of the recommendation, also they suggest to start give a dose of around 40,000 international unit of PERT therapy with the major meals, and around half of the dose like 20,000 international unit with the minor meals or with snacks. And if the PERT is if the patient is not responding to the PERT, then we can increase the dose, and we can also check for the compliance with the patient. Apart from this, we have to look for the nutritional status of the patient, and we also have to supplement all the fat soluble vitamins like vitamin D, calcium, vitamin A if the patient has a deficiency and patient is developing vitamin A deficiency symptoms, and sometimes vitamin K also. Next. So the role of pancreatic lipase, as I have discussed, it improves the symptoms, it improves the fat and the protein absorption, it reduces the steatorrhea, improves glycemic control, improves postprandial glycemia, it improves the incretin hormone response, and overall it improves the quality of life. Next. So this is how the exocrine pancreas it influences the insulin. So whenever there is exocrine pancreatic insufficiency, happens in a chronic pancreatitis, so there is a decrease in the insulin delivery to the draining microvessels. There is also obstruction of access of the insulin to the blood vessels, obstruction to the intrapancreatic insulin circulation, and there is damage to the endocrine tissue and impact on the beta cell neogenesis. So it has been found that enzyme replacement therapy, they might have an impact on the glucose metabolism, as it can reduce the insulin requirement. Next. So this was a study which compared about the high dose and low dose pancreatic enzyme therapy. So compared to those with low pancreatic enzyme concentration, those with a high pancreatic enzyme concentration had a higher insulin concentration at 9 minutes after the carbohydrate ingestion in study. And they also found a higher insulin area under curve concentration for the high dose insulin therapy as compared to the low dose at 9-minute period. And low insulin concentration is also associated with a decreased basal insulin level, insulin secretion, and high insulin resistance. And they found it helps to improve the blood glucose control and reduce the HbA1c. Next. And supplementation with pancreatic enzyme, it also improves the fat and the protein absorption in exocrine pancreatic insufficiency with diabetes. Next. So pancreatic enzymes and incretin response. So pancreatic enzymes, it increases the postprandial response to the GLP-1. So supplementation with the pancreatic enzyme, it improves the glucose metabolism by restoring the activity of incretins such as GLP-1. And in a study, they found that pancreatic enzyme supplement, they normalize the gastric emptying, normalize GLP-1 secretions, and tend to increase the glucagon. And pancreatic enzyme also triggers incretin secretions. And the following things were observed with a pancreatic enzyme supplement, like a higher total GLP-1, higher total GIP response, increased plasma insulin secretion, increased plasma C peptide secretion, and increased total insulin secretion. Next. So coming to some case-based studies. So the first case, a 46-year-old male with type 2 diabetes with recurrent gallstone pancreatitis with HbA1c of around 10. So in that patient, pancreatic enzyme supplements were started, And finally, the HbA1c was reduced to 6.7 with also resolution of the high triglyceride level. A second case, a 57-year-old with a high triglyceride-related pancreatitis and type 2 diabetes mellitus. He was also diagnosed as a diabetes with HbA1c of 9.7, along with elevated total cholesterol and high triglyceride level. Pancreatic enzyme supplement was started, and there was improvement in the HbA1c level, along with high triglyceride and total cholesterol level. Case 3 was a 24-year-old with a cystic fibrosis related diabetes mellitus with a HbA of C1 8.6. Enzyme replacement lead to reduction in both in the HbA1c and also in the high triglyceride level. And the last case about the 36-year-old male with a prior well-controlled diabetes mellitus and a known MEN1 with HbA1c of 11.3. In this patient also pancreatic enzyme replacement reduced the HbA1c and also improved the triglyceride and the total cholesterol level. Next. So, coming to the safety and efficacy of the pancreatic enzyme supplement, as we know, pancreatic enzyme supplements, they are very safe, and the most common side effect which we commonly see in a patient using pancreatic enzyme supplement is like nausea, and sometimes abdominal cramps, and sometimes diarrhea. And apart from this serious side effects, sometimes it has been recorded, especially in the pediatric population, like fibrosing colopathy. But in the adult, we have not come across any such cases. And sometimes hyperuricemia can also develop. And most important thing which one should know is that most of the pancreatic enzyme supplement, they has a porcelain base. There is no, they do not come from the human source. So if the patient has any allergy or any problem with the porcelain base, so in that case we have to make it sure that the patient is not allergic to all those things. Next. So finally, to conclude, exocrine pancreatic insufficiency is common in diabetes. Exocrine pancreatic insufficiency, they can impact the treatment and the outcome of diabetes. Treating exocrine pancreatic insufficiency has several benefits. Pancreatic enzyme supplementation, it helps to improve the response to treatment. Enzymatic supplement, it improves the insulin response and incretin response. And enzymatic supplementation is safe and it is very well tolerated. Thank you.
Thank you so. Thank you so much for explaining this very less discussed topic but very important topic of EPI with the diabetes coexistence. So I request now all the viewers to post their queries. If you have any queries, you can post that, and after that we can close the session.
Okay.
So there is no query, sir, from
Okay.
your side. So thank you so much once again for giving your valuable time for us for this important topic, sir. And we are looking forward for the longer association.
Sure, sure. Thank you very much.
Thank you so much, sir. Thanks a lot. Good
Good
evening.
night.
Thank you all the viewers. Sorry, but there is now one query has come. If you
Okay.
could answer.
Sure,
Please
sure.
repeat the dosages of pancreatic enzyme for severe pancreatitis patients.
This is a very good question. Actually, this is a very practical question, I would say. In a
Hmm.
patient with severe pancreatitis,
Hmm.
as per the recommendation, we generally start with a very higher dose. If the patient is a severe pancreatitis, like 40,000 international unit, we ask the patient to take this dose with meals, or we can distribute if the patient is not able to take orally, if the patient is in the rice tube feeding. So in that case we ask the patient to take the similar dose throughout the meal, not with meal also he can take, but not before meal. And if the patient is taking a minor meal, say for example if the patient wants to take snacks in between, so in that case we ask the patient to take a dose of around 10 to 20,000 with a minor meal. So it is very important to understand that with all the major meals, if the patient has severe pancreatic insufficiency, give a dose of around 40,000 to 50,000, and with the minor meals give a dose of around 20,000.
Great.
But the main issue with all these things is that the cost of the therapy, because in most of the uh, formulations we have around 25,000 only as a maximum dose. So for giving such a high dose with the major meal, we have to give two capsules with the major meals and one capsule with the minor meal. So in that case, throughout the day, the patient has to take around 6 to 8 capsules per day.
True, sir, true. In that case, cost of the therapy goes up for the
Exactly.
patient. But
Exactly.
that
So
is why, yeah.
but all practical purpose, we generally, if the patient has severe pancreatitis, if the patient is compliant, if the patient is affordable, so in that case we suggest to take around 6 to 8 capsules. But if the patient is poor and he is not able to take so many capsules per day, so in that case we generally give around 25,000 for thrice daily
Okay.
with the major meals only.
Yes, sir. Yes, sir. And that is the reason only that our Enzelo, the pancreatine, is coming with very much affordable cost for you patients.
Yeah, this will help a lot of the patient, because see, once a patient develops a exocrine pancreatic insufficiency, it is not a 1 day or 2 day treatment. The patient has to
Yes.
take this medicine lifelong. So if the medicine is very costly, then the most of the patients they're not able to take the medicines for a longer time. And we have seen a lot of patient who had developed a very good response to the initial therapy, later on coming with a lot of complications, because they left taking medicine because of the cost issues.
They withdraw themselves in between from the
Exactly.
therapy because of the cost factor.
Exactly.
Then one more question is there. If the I mean, I think it is a capsule. That the person mean to say that if it is a capsule of 25K, then it have to be taken 2 or 3 tablets at a time, or two or
Two
three
capsules.
capsules at a time. Two, correct. So these were the questions. And once again, thanks a lot, sir, for giving your precious time for us. Thanks a lot. And I assure you that Angelo will be helping for most of your patients in these kind of cases, sir. Thank you
Sure,
so
sure.
much.
Okay, thank you.